Hello everyone. Tonight's lecture will be on cardiorespiratory fitness, and the information will be coming from the ACMSM's guidelines for exercise testing and prescription, as well as the ACSM's fitness assessment manual. Why measure cardiorespiratory fitness? CRF is a measure of how efficiently your heart, lungs, and muscles deliver and use oxygen. And because it involves all these major systems, it's basically the ultimate assessment for your whole body's health, a key vital sign for long-term wellness. You will see some terms that are used to describe CRF are maximal aerobic capacity, functional capacity, physical work capacity, cardiovascular endurance, fitness or capacity, cardiovascular endurance fitness or capacity, cardiopulmonary endurance fitness or capacity. And again, these are just some terms that you will see used to describe CRF. The gold standard for measuring CRF is a maximal exercise test with a collection of expired gases. And because this method actually involves time, cost, and skilled personnel, as well as a higher level of risk, it is not always feasible or desired. Field tests used for the prediction of CRF can occur in various non-laboratory settings. They can either be maximal, which are tests that push your body to absolute exhaustion to measure peak physical capacity, or they could be submaximal, which are tests that evaluate your cardiovascular fitness without pushing your body to absolute exhaustion. These tests can be administered to a group of people simultaneously. They require participants to complete a certain distance as quickly as possible, cover as much distance as possible in a fixed amount of time, or perform a set amount of work in a fixed amount of time. There are three types of tests that we will discuss on the next few slides. One is the step test. There's a fixed distance test and the fixed time test. Step tests are usually performed with younger populations, and the protocol must be appropriate for the physical fitness level of the participant. Once protocol is selected, the height or the cadence, all procedures must be followed as it impacts the accuracy of the test. The Harvard two-step test was first used in medicine to aid in the diagnosis of heart disease, but many alternate methods have been developed since that time. There's the Ashram-Rhyming, Webb, YMCA, Queens College, and the STEP tool. These are all different types, different methods that can be used for STEP tests. Fixed distance tests are classified into walk-run tests where the participant walks or runs or uses a combination of both to complete the test, or a pure walk test where the participant is strictly limited to walking the entire test. There's also the 1 mile walk test, but for this test you have to make sure there's an accurate body weight prior to the test. You have to have a clock to time the duration of the walk, and the ability to measure the participant's heart rate at the completion of the walk, because the completion heart rate is considered the peak heart rate. And the formula to calculate the estimated CRF is listed in the box below. And in order to use the formula, you have to make sure that the weight is calculated in kilograms, the age in years. Used for the sex, women would be 0, men would be 1. The time has to be in minutes, so if it's seconds that you've used, you have to make sure you convert that to minutes. The heart rate has to be in beats per minute as well. And these, once you substitute these values into the formula, then you can calculate the estimated CRF. The fixed time test is another test that can be used, and it requires the participant to cover a maximum possible distance in 12 minutes by walking or running or using a combination of both. The distance covered in 12 minutes needs to be measured and expressed in meters. And once the test is complete, the CRF can be estimated using the equation listed in this slide. And for example, let's say an individual did 1 mile in 12 minutes. So if we want to calculate the CRF, we would take the distance, which is 1 mile, which is also 1,609 meters. We would subtract 504.9, which is listed in the formula, from that, and then divide that by 44.73. And when you do that, your answer is 24.69 milliliters per kilogram per minute CRF. There are some assumptions for submaximal exercise tests. One, for a single individual, as your heart rate goes up, your oxygen consumption goes up in a perfectly straight, predictable line. Two, because maximum heart rate naturally declines over a lifetime, we often estimate maximum heart rate using a person's age. However, there's a huge margin of error in these estimates. This variability causes the biggest problems when we try to predict CRF using a submaximal ergometer test. Three, when you start exercising at a steady pace, your heart rate doesn't jump to its final number instantly. It takes about 3 to 4 minutes of keeping that exact same pace for your heart to catch up, level off, and find its rhythm. We call this flat line your steady state heart rate. Getting to that steady state is a secret to making sure your final fitness prediction is actually accurate. 4, most cyclists can pedal smoothly and efficiently at 50 RPMs. Even though it's not the most comfortable pace for everyone, everyone burns the exact same energy to hit a specific workload. Because of this, it's the basis for ACSM's metabolic calculations. 5, pedaling at 50 RPMs is generally comfortable and highly efficient for most people, though it's not a universal favorite. ACSM's metabolic calculations are built on the foundational assumption that anyone doing the same amount of cycling work, regardless of their comfort level, will burn the exact same amount of energy and need the same amount of oxygen. 6, during multi-stage tests, like the YMCA cycle or Bruce treadmill, you measure heart rate at 2 different effort levels. By tracking this, you can estimate how heart rate rises with oxygen intake and project it out to the maximum heart rate to predict fitness. The Astran protocol relies on only one stage. Therefore, this multi-point prediction method doesn't apply. There are also other sources of error that include prediction of heart rate max by age, efficiency of the participant performing the test, equipment calibration, although sometimes taken for granted. Calibration is vital to the accuracy of the test results, and accurate measurement of heart rate during each stage. Submaximal exercise testing is one that requires the participant to perform a fixed amount of work per unit of time. And in many cases, these tests require multiple stages or levels. The key distinguishing feature of these tests is that they limit the participant's effort to less than maximal exertion. There are several protocols that may be used to conduct submaximal exercise tests to predict CRF using various testing modalities, from the bench step to the cycle ergometer to the treadmill. When deciding on which method to use, We have to make sure that we keep in mind that to evaluate CRF, the maximal effort test is a gold standard. However, individual status must be used to determine what type of test to complete. Also, it provides the most information as well as keeping the participants safe. These are all things that must be considered when you're making that decision. Also, there are other factors that must be considered, and these include the reasons for the test, the level of risk, cost, time, personnel, as well as equipment and facilities. Box 4.4 highlights the pre-test standardization for CRF assessments. And to get the best results from an assessment, you should brief participants on specific pre-test preparations, cover screening, explain to them how to communicate symptoms, and use the Borg RPF scale. You can give the participants a checklist, which actually tells them about what type of clothing to wear, comfortable clothes, shoes suited for exercise, diet, the things to avoid, like tobacco and caffeine for 3 hours prior, avoid alcohol for 12 hours, also stay well hydrated. You should also talk to them about activity, no strenuous exercise for 24 hours before the test, and to rest well the night before. Also, you should, some of the things that must be done is ensure that the informed consent is reviewed and signed. The screening, have the participant complete the PARQ, the physical activity readiness questionnaire, and then go through the instructions again on how the test will work. And then during the assessment, you want to make sure the participant knows they are in control. Their rights, they can stop the test at any point for any reason. They can tell you immediately if they feel unusual symptoms like chest discomfort or severe fatigue. And if you're using the Gunnar-Borg's rating of perceived exertion or the RPE scale, read the standardized directions so they know how to grade their physical effort during the test. A fundamental feature for many submaximal exercise tests is the reliance on knowing the participant's maximum heart rate. And because the measurement of maximum heart rate requires a maximal exercise effort, the participant's maximum heart rate cannot be obtained during a submaximal exercise. And this procedure depends on the prediction of the participant's maximum heart rate. And there is a formula that is used mostly, and it is the age predicted heart rate maximum, which equals 220 minus the age in years of the participant. So if it was a female, you would say a female that was age 40, it would be 220 minus 40, and that would be the age predicted heart rate max. There's also, on the next screen, the Tanaka formula, which is a widely used equation to predict maximum heart rate. And it was developed in 2001 by researchers analyzing over 350 studies, and it's more accurate across different ages and fitness levels. And as you will see, there is a difference between the men and women. And that is one of the things that makes this test a little more accurate. There must be a solid plan for when to end the session before it starts. And while general formulas exist to estimate the exertion levels, they are based on averages and may not accurately reflect every individual's physical limits. Therefore, it is critical to continuously monitor the patient or the participant for any indications of overall exertion or distress. Some general indicators for stopping the exercise test are as listed below: onset of angina or angina-like symptoms, drop in systolic blood pressure, exercise rise in blood pressure, shortness of breath, signs of poor perfusion like lightheadedness, confusion, ataxia, pallor, cyanosis, nausea or cold and clammy skin, failure of heart rate to increase with increased exercise intensity, noticeable changes in the heart rhythm, subject requests to stop, physical or verbal manifestations of severe fatigue, or failure of the test equipment. And this information is found in box 4.5 in your textbook. Also, there has to be monitoring for signs of distress. And while the blood pressure monitoring is not used to determine CRF, it is used as a proactive measure to see how the participant's body responds during physical activity. Though the cycle ergometer is a standard choice for submaximal testing, any testing mode works as long as it allows for standardized workloads and provides established estimates of relative oxygen consumption. The field test, which is performed outside of laboratories, may consist of walking, running, or stepping. And then there's also treadmills. And although there are many different treadmill protocols, a common one used for submaximal assessments is the Bruce protocol. Most participants should be able to obtain two heart rate values between 110 and 150 beats per minute within the first 3 stages, each 3 minutes in duration of this protocol. There are 2 protocols for estimating the VO2 max using the cycle ergometer test. One is the YMCA, which involves plotting the data on a graph called a nonogram, detailed in the fitness assessment manual. And then the second one is the Astran rhythming, which uses a calculation-based formula. And this formula is as indicated below. And for this, the steps for this procedure, once you prepare the test, you choose your protocol. So if you're using the Astran rhyming method, you would take the average heart rate from the 5th and 6th minutes and the chosen workload in watts or kilograms per minute. And then you would plot these 2 points on a nonogram and draw a straight line between them. The point where your line intersects the center axis gives you your estimated VO2 max in liters per minute. You could then multiply by 1,000, then divide by your body weight in kilograms to get the relative value in milliliters per kilogram per minute. The YMCA method plots your workload on the horizontal axis, the x-axis, and a steady state heart rate for each stage on the vertical axis, the y-axis. And this graph is also indicated in our workbook. You would draw a line best fit through these points and extend it up to your age predicted maximum heart rate, the 220 minus the age. And then you would drop a perpendicular line down this point at the intersection to reach your estimated workload at maximum heart rate. And then you would plug this into the metabolic equation to derive at your VO2 max. Whether using field tests or submaximal exercise tests, when we're doing interpretation, we must remember that the maximal oxygen consumption is an estimate, and therefore we should use the standard error of estimate, which is the SEE, to show that margin of error. And there are some things that we must remember, they're quite important. The AHRSS is obtained for each exercise work rate. There is a linear relationship that exists between the HR and work rate. Mechanical efficiency is the same for everyone. Participant is not on any HR or heart rate altering medications. The participant's limit caffeine consumption prior to testing, and he or she is not ill or in high temperature environments, all of which can alter HR responses. Some sources of error in submaximal prediction are age predicted maximum heart rate variable, the mechanical efficiency variation, and the day-to-day heart rate fluctuation. These are all considered errors. Maximal exercise testing, fitness levels can be estimated using shorter submaximal tests, but we must understand that maximal exercise test is a gold standard measure for CRF and are necessary when there is a need for precise results to make medical decisions. And whether to do maximal tests in a gym or a medical setting will depend on several factors, including the training level of the testing staff. While exercise is fantastic for your health, it comes with a few risks, and especially with increased intensity. Pushing bodies to the maximum carries a higher risk than lighter submaximal fitness assessments. And before beginning any assessment, participant consent and at a minimum, a PRQ plus must be completed as a screening tool. Before anyone starts an exercise test, you must thoroughly screen them for any red or yellow flags. Always check the specific contraindications as outlined in box 5.1. And remember, in a gym or fitness setting, treat any unexplained symptom as a potential risk factor and play it safe. Some of the absolute contraindications include acute myocardial infarction within 2 days, ongoing unstable angina, active endocarditis, symptomatic severe aortic stenosis, decompensated heart failure, acute aortic dissection, physical disability that precludes safe and adequate testing. Some of the relative contraindications are known obstructive left main coronary artery stenosis, acquired, advanced, or complete neck block, recent stroke or transient ischemia attack, mental impairment with limited ability to cooperate, uncorrected medical conditions such as significant anemia, important electrolyte imbalance, and hyperthyroidism. These are all contraindications, and they must be considered as risk factors and addressed. Monitoring, and during a maximal fitness test, the main goal is the test measures how efficiently your heart and lungs deliver oxygen to your muscles during intense exercise. How things are measured, which means you exercise to your absolute limit while wearing a mask that analyzes the air you breathe in and out. And then, of course, safety first. The trained staff will watch your heart rate and watch closely for any signs that you need to stop for safety. And then there's a deeper monitoring, because in clinical settings, they will likely also track your blood pressure, heart's electrical activity or ECG, and your oxygen levels to get a full picture of your health. There are 3 areas that must be considered when you're talking about monitoring. The first is personnel. And it's usually standard is a team approach. The staff will track the vitals like the heart rate, blood pressure, oxygen levels, while keeping an eye on the participant's effort level and breathing. And even if there's trained staff directly supervising, if it's a diagnostic test, then a MD, a physician assistant, or a nurse practitioner must be present or easily available. However, certified clinical staff such as an ACS MCEP can administer maximal tests if they have the right skills or experience. And also, looking at the participants, if they're healthier and require less intensive monitoring, this will help determine the amount of staff or personnel that would be required for the test. The second area would be the test operator, and this depends on the facility. Participants will complete a pre-screening paperwork either prior to or immediately before their test. Staff will review this with them to clear their any health risk. Also, the staff will make sure to review the informed consent document and answer any participant questions and clearly explain the testing procedures. The supervisors need to ensure that the participant understands the nature of the test, as they will work to a maximal effort level, but can stop at any time and must immediately report any unusual symptoms, especially chest discomfort. And finally, the supervisors must ensure the participant understands and can use the RPE scale. And the last area would be the staff responsibilities during the test. And those responsibilities include continuously monitoring the participants' well-being, the posture and symptoms, track and log the heart rate, the blood pressure, the respiratory beats, RPE, and any physiological symptoms. They're also to manage the metabolic cart, controls workloads, and changes and handles pre-test calibration and post-test sterilization of equipment. When selecting the mode for testing, the treadmill is the standard default for most people. And this is usually because walking is something that we do daily, is comfortable, it produces highly accurate results, and it pushes the body hard enough to get a true VO2 max reading. Cycloergometers is a better choice if you're working with trained cyclists, people with balance issues, leg pain, or people living with obesity. And the rationale behind that is that the bike supports the body weight, which means the leg muscles won't get tired as fast. And arm ergometers can be used so individuals, even those with severe lower body injuries, can still get a good workout. Once the decision on the type of exercise is made, the next step would be choosing a protocol. And facilities usually set one standard default so that they can easily track typical responses as well as compare results. There are some commonly used protocols, such as the Bruce protocol, bulky wear protocol, running protocols, cycle protocols, and there's also individualized protocols. To fine-tune a protocol or to build a new one, there are factors that must be kept in mind. And these factors are the target time, the work rate, the treadmill settings, ramp testing versus stage testing. All of these things are very important and must be taken into consideration when you're trying to either tweak or build a new protocol. Several research reports have provided regression equations to obtain an estimate of VO2 max from exercise test duration. When using prediction models, it is essential that the identical protocol is followed for the test and that the subject is not allowed to use handrail support during the treadmill test. It is also desirable to match the characteristics of the subject to the general characteristics of the population that was assessed in the original study. Box 5.3 provides prediction equations for the Bruce BSU/Bruce ramp, and the bulky wear protocols. The standard area of estimates range from plus or minus 2.7 to plus or minus 4.7 NL per kilogram per minute. Box 5.7 also provides estimates for the modified bulky wear protocol used at the Cooper Clinic. Another approach to obtaining an estimate of VO2 max is to use the ACSM metabolic calculations, which will be found in Chapter 6 and discussed at that time. However, this method is not desirable because the metabolic calculation equations were developed for steady state submaximal work rates. However, for cycle testing or other treadmill protocols without prediction equations based on test time, they're sometimes helpful. Thank you, everyone, and have a very good evening or morning, whichever it is when you get this lecture. I hope it is presented in a manner that is useful. Thank you again.